Medical OBG series. So today we are going to see some of the importance of various history that is taken in the first trimester, second trimester, and third trimester. All the why, what are the certain relevance of the history. So coming to the first term, which is hyperemesis gravidarum. So hyperemesis gravidarum, what is it? Hyperemesis gravidarum refers to excessive vomiting in pregnancy that has got deleterious effects on the health of the mother. So, excessive vomiting in pregnancy, which is having a deleterious effect on the health of the mother, is hyperemesis gravidarum. So, the causes of hyperemesis gravidarum are molar pregnancy, multiple pregnancy, and and it is more common in primigravida. So hyperemesis gravidarum, guys, it's defined as excessive vomiting in pregnancy, along with deleterious effects on the health of the mother. So the three major causes are molar pregnancy, multiple pregnancy, and it is more common in primigravida. Now next, any previous history of hyperemesis, strong family history, non-obstetric causes for vomiting. So what are all the non-obstetric causes for vomiting? This can be a viva question. So the non-obstetric causes for vomiting, first the medical causes, it can be due to any UTI, hepatitis, diabetic ketoacidosis, peptic ulcer. Surgical causes such as appendicitis and cholecystitis. Gynecological causes like twisted ovarian cyst, red degeneration of fibroid. All of these are non-obstetric causes for vomiting. Now next, coming to bleeding PV. So bleeding PV, the causes of bleeding PV in first trimester are going to be implantation bleeding, abortion, ectopic pregnancy, molar pregnancy, and certain local lesions like cervical erosion, polyp, carcinoma cervix. All of these are causes for bleeding PV in the first trimester. So very important, the bleeding PV causes of first trimester are implantation bleeding, abortion. Abortion is the most common cause. This is a very important question. What is the most common cause of bleeding PV in the first trimester? It is abortion. And others are implantation bleeding, ectopic pregnancy, molar pregnancy, any local lesions like cervical erosion, polyp, carcinoma cervix. All these are causes for bleeding PV in the first trimester. So certain viva questions let us discuss. So what is implantation bleeding? So implantation bleeding is, in some women, spotting PV may occur approximately on the day of expected menstruation due to implantation of fertilized ovum that may be confused with the LMP. So in some women, spotting PV is approximated during the day of expected menstruation, and it can be confused with LMP. So this is referred to as implantation bleeding. There might be a discrepancy in the gestational age in the women who have the implantation bleeding. So implantation bleeding is very simple. So generally implantation means what? The fertilized ovum is going to be getting the embryo will be attached to the uterine wall. That process is known as implantation. So usually there will be no symptoms during implantation, but in some women there will be some bleeding or some spotting PV. Okay, some spotting PV, and usually some women can get this confused that it is a period, but it is not a period. Usually implantation bleeding lasts for around just one very few hours to 1 day or 2 day maximum, but whereas periods last for around 3 to 5 days, right? And the flow is going to be heavy, whereas it's just spotting PV in case of implantation bleeding. So what is the problem with implantation bleeding? So if suppose so the woman is getting confused with the period, so then then the LMP dates will be changed. So if so basically the woman is conceived, and but the woman does not know that she is pregnant, and she is confused with the last menstrual period. So this is what is referred to as implantation bleeding, and there might be a discrepancy in the gestational age in women who have implantation bleeding. So this is the major problem, discrepancy. So the gestational age, there will be a discrepancy in the gestational age, and that is the main point that you need to know with implantation bleeding. Now, so abortion. So what is abortion, guys? Expulsion of the products of conception before the period of viability is known as abortion. So what are the different types of abortion? So there are different types of abortions. First, coming to threatened abortion. Then we have inevitable abortion, and then incomplete abortion, complete abortion, as well as a missed abortion. So there are 5 major types of abortion, guys: threatened abortion, inevitable abortion, incomplete abortion, complete abortion, and a missed abortion. So what are the first moving in detail about threatened abortion? So what are the clinical features in case of threatened abortion? First is pain in the abdomen, spotting or bleeding PV. So these are the 2 major complaints: pain in the abdomen, abdominal pain, spotting or bleeding PV. These are the clinical features in case of a threatened abortion. Now if you look at so when you do a per abdominal examination in case of threatened abortion, fundal height corresponds to the period of gestation. Per vaginal examination, spotting will be seen and cervical os is going to be closed. And in ultrasound, the cardiac activity will be good. So this is all about threatened abortion. So threatened abortion, the main clinical features are abdominal pain, spotting and bleeding PV. In case of per abdominal examination, the fundal height will be corresponding to the period of gestation. In per vaginal examination, spotting will be there, cervical os is going to be closed, and cardiac activity is going to be good. Now next, moving on to inevitable abortion. In inevitable abortion, pain in the abdomen will be there along with bleeding PV. The fetal in per abdominal examination, the fundal height may correspond to the period of gestation. Bleeding will be there, and os is going to be open here. So os will be open in case of inevitable abortion, and cardiac activity is seen. Next, coming to incomplete abortion. So pain in abdomen, bleeding PV. The fundal height will be less than the period of gestation. Bleeding is seen, os is open, and in ultrasound, retained products of conception is present. So the products of conceptions are going to be basically retained. Now next, coming to complete abortion. So clinical features of complete abortion is pain is going to be subsided, minimal or no bleeding per vagina. So in per abdominal, it's going to be a normal uterine size. In per vaginal, no or minimal bleeding, and os is going to be closed, and the uterine cavity is going to be empty. Now next, coming to the missed abortion. Clinical features: no symptoms or bleeding PV. Per abdominal examination, the fundal height will be less than the period of gestation. Per vaginal examination, altered blood stain, discharge, and os is going to be closed, and the cardiac activity is going to be absent. So these are the 5 types. Threatened abortion, mainly you need to remember that you have pain in abdomen, spotting, fundal height corresponding to POG, the cervical os will be closed. Inevitable abortion, the cervical os is opened. In incomplete abortion, the cervical os is opened. In complete abortion, the cervical os is closed. So these are the types of abortion. So in the figure A, if you see, it's a threatened abortion where the cervix is closed and it's just presented with spotting PV. So this is a threatened abortion. And in the second figure, it is an inevitable abortion. So in inevitable abortion, the cervix is going to be open. So there is a dilated cervix with low-lying products and active bleeding. So active bleeding will be there in case of inevitable abortion. And the last one is the incomplete abortion. Incomplete abortion, which means there are some retained products present. Retained products of abortion are present, and there is no gestational sac. So very important, in which abortion type will you have empty will you have an empty uterine cavity is complete abortion. Only in complete abortion, if you do an ultrasound, you get an empty uterine cavity. Now next, about the history of fever with rashes. A high grade fever can lead to abortion, intrauterine death and preterm delivery. So the causes of fever with rashes are rubella, chickenpox and measles. So what are the causes for fever with rashes? Rubella, chickenpox, which is varicella, and measles. Now next, coming to exposure to radiation. So what are all the radiation hazards? Teratogenic effects can occur when the cumulative dose of radiation exposure is greater than or equal to 5 rad. Very important. So radiation hazards, the cumulative dose of radiation exposure is greater than or equal to 5 rad. Radiation exposure in the first trimester can be associated with an increased risk of childhood malignancy. Common indications for radiation exposure. So childhood malignancy, so radiation exposure in the first trimester has an associated risk of childhood malignancy. So common indications for radiation exposure during pregnancy are: first, maternal reasons. The patients with cardiac or pulmonary diseases may require chest x-rays. Patients with bone fractures may require x-rays. So let's look at some high yield points. So talking about the rubella infection during pregnancy, the risks of major fetal anomalies are 50%, 25% and 10% when infection occurs in the first, second and third trimesters respectively. That is, the risk of rubella infection during pregnancy is more during the first trimester. Now, what is congenital rubella syndrome? So congenital rubella syndrome includes a multi-system abnormality, such as, it's a triad of sensorineural deafness, congenital cataract, and cardiac defects. So congenital rubella syndrome, there is a triad of sensorineural deafness, congenital cataract and cardiac defects. Cardiac defects like patent ductus arteriosus and septal defects. So the triad is sensorineural deafness, congenital cataract and cardiac defects. Next, coming to hematologically, anemia and thrombocytopenia. Hematologically, anemia and thrombocytopenia, hepatosplenomegaly, osteopenia, chromosomal abnormalities. Medical termination pregnancy is advised when acute rubella infection occurs during pregnancy, that is IgM antibody. So these are about congenital rubella syndrome. You need to remember this triad: sensorineural deafness, congenital cataract and cardiac defects. Along with that, you will be having anemia, thrombocytopenia, hepatosplenomegaly, osteopenia, chromosomal abnormalities. So, rubella vaccine is a live vaccine given to non-immunized, non-pregnant women. Rubella vaccine is not recommended during pregnancy, and pregnancy should be avoided within 3 months of vaccination. Now, next, coming to varicella infection during pregnancy. So, varicella infection during pregnancy, the risk of congenital malformation is more when infection occurs in the first trimester. Congenital varicella syndrome. So, what is congenital varicella syndrome? Congenital varicella syndrome is characterized by the following. First is limb hypoplasia, limb deformity, chorioretinal scarring, microcephaly, and cutaneous scarring. Limb hypoplasia, limb deformity, chorioretinal scarring, microcephaly, and cutaneous scarring. Okay, so congenital varicella syndrome includes limb hypoplasia, limb deformity, chorioretinal scarring, microcephaly, and cutaneous scarring. Varicella vaccine is a live attenuated vaccine contraindicated during pregnancy. Varicella zoster immunoglobulin should be given to exposed and non-immune patients. Varicella zoster immunoglobulin should be given to newborns in case of exposure to infection within 5 days of delivery. Next, coming to measles during pregnancy. Measles during pregnancy is not teratogenic. However, any high-grade fever during pregnancy can lead to abortion, intrauterine death, and preterm delivery. So, the fetal reasons for radiation exposure have become obsolete with the availability of ultrasound and MRI. Coming to the drug intake. Periconceptional, very important. So, drug intake, periconceptional folic acid intake, which is 500 mcg. The dose is always a favorite Viva question, guys. So, periconceptional folic acid intake is 500 mcg OD orally. It decreases the incidence of neural tube defects. Teratogens are chemicals or physical agents that cause permanent alteration in structure or function of an organ during embryonic or fetal life, resulting in congenital malformations. So, certain examples of teratogenic drugs are going to be antiepileptics like phenytoin, valproate, antihypertensives like ACE inhibitors such as captopril, enalapril, anticoagulants such as warfarin, antibiotics such as tetracycline and chloramphenicol. All these are teratogenic drugs. Okay. So again, antiepileptics, antihypertensives, anticoagulants like warfarin, antibiotics like tetracycline and chloramphenicol. So, what are these safe antibiotics in pregnancy? So, safe antibiotics are penicillin, cephalosporins, and erythromycin. So, there is something known as rule of 10. So, what is this rule of 10? So, rule of 10 says that no woman should be exposed to radiation 10 days outside her LMP. So, this is the rule of 10. So, the rule of 10 states that no women should be exposed to radiation 10 days outside her LMP. Now, the radiation exposure in various investigation procedures, say chest X-ray, the dose is less than 0.001. Abdominal X-ray, the dose is 0.3. Pelvic X-ray, the dose is 0.5 to 1. Abdominal CT, the dose is 0.5 to 1. So, these are the RADs, okay. Now, ultrasound and MRI are devoid of any ionizing radiation. So, the risk category as per Food and Drug Administration of drugs during pregnancy are category A, B, C and D. So, definition. So, category A is safest drugs during pregnancy. So there is no fetal risk in well-controlled studies. In category B, no evidence of fetal risk in humans. So well-controlled studies show no fetal risk despite the risk in animal studies. Category C, fetal risk cannot be ruled out. Potential benefit may outweigh the risk. And the remark is well-controlled studies in humans are lacking. Category D, positive evidence of fetal risk, potential benefit, life-threatening situations may outweigh the risk. And the remark is studies in humans have demonstrated the risk. And category X is contraindicated in pregnancy. Why? Because of the potential fetal risk. For example, AC inhibitors, mifepristone, danazol, isotretinoin, methotrexate, radioactive iodine. So this is all the importance of history that is during the first trimester. Now let's move on to second trimester. So first, the main thing you need to ask is the number of antenatal visits. It is required to know the booking status, if the pregnant lady is booked or not. Next, moving on to the tetanus toxoid immunization. So tetanus toxoid immunization is given during pregnancy to prevent neonatal tetanus. So if you look at tetanus toxoid, it is safe during pregnancy and the dose is 0.5 ml given intramuscularly in the deltoid or the upper outer quadrant of the buttocks. So it is either given in deltoid or in the upper outer quadrant of buttocks, and usually it is 0.5 ml intramuscular injection. So the National Immunization Schedule in India recommends generally 2 doses of tetanus toxoid for unknown immunization status of pregnant women. So coming to the first dose. The first dose of tetanus toxoid is administered as soon as pregnancy is detected. In many clinics, it is administered at 16 to 20 weeks when the patient comes to get anomaly scan done. The second dose of tetanus toxoid is administered 4 weeks apart the first dose, or at least 4 weeks prior to EDD. This is very, very important. So first dose is administered as soon as the pregnancy is detected. The first dose is given and 4 weeks apart. So 4 weeks apart. 4 weeks apart, the second dose is given. The second dose will be given. So as soon as the pregnancy is detected, you give the first TD dose. 4 weeks apart, you give the second TD dose. Now, if a mother received 2 TT doses in the last pregnancy and the next pregnancy is within 3 years, then only 1 booster dose of tetanus toxoid is recommended. Now, say if the mother has been immunized with 2 TT doses in the last pregnancy and the next pregnancy is actually less than 3 years, okay, is within 3 years, then just 1 booster dose of TT is recommended. That's all. You don't have to repeat giving again the 2 doses. So according to WHO, the WHO recommends a third dose of tetanus toxoid. Okay, a third dose of tetanus toxoid to be given 6 months after the second dose to provide protection for at least 5 years. So if the mother wants to be protected for at least 5 years, then after the second dose, around 6 months later, you give a third dose. So what is warfarin embryopathy, guys? Warfarin embryopathy, see, warfarin intake during organogenesis period can actually result in fetal anomalies termed as warfarin embryopathy or Conradi syndrome. Very important. Warfarin embryopathy is otherwise known as Conradi syndrome. Conradi syndrome. So what does this Conradi syndrome comprise of? Conradi syndrome includes the skeletal and facial anomalies, optic atrophy, microcephaly, chondrodysplasia punctata. So these four things, Conradi syndrome or Warfarin embryopathy includes four things. One is skeletal and facial anomalies will be there, optic atrophy will be there, microcephaly will be there, and chondrodysplasia punctata will be there. Skeletal and facial anomalies, optic atrophy, microcephaly, chondrodysplasia punctata. Now next, moving on to quickening. So what is the definition of quickening? Perception of fetal movements for the first time during pregnancy. Okay, so the perception of fetal movements during first time of pregnancy is called as quickening. So quickening is usually felt at 16 to 20 weeks in primigravida, 18 to 20 weeks in primigravida, and 16 to 18 weeks in multigravida. That is, in case of multigravida, the quickening is felt earlier, because a multigravida feels earlier because she already knows how a fetal movement looks like. It's just common sense. So significance of quickening, it assures a live fetus at the point of time. Date of quickening may be helpful in calculating the period of gestation in case of irregular cycles or if last menstrual period is not known. So in case of primigravida, the quickening plus 20 weeks will give you expected date of delivery. Okay, so in primigravida, the quickening plus 20 weeks will be your EDD. In case of multigravida, quickening plus 22 weeks will be your EDD. Quickening plus 20 weeks for primigravida and quickening plus 22 weeks for multigravida. So coming to the bleeding per vaginum in case of second trimester. So in second trimester, you ask for the history of bleeding PV. So what are the causes of bleeding PV in second trimester? Very, very important question. So as usual, the first cause is abortion, second is molar pregnancy, and third one any local lesions like cervical erosion, polyps, and cervicitis. So coming to the drug intake, iron and calcium supplementation is started when the nausea and vomiting of pregnancy settles down, usually around 14 weeks. So recommended prophylaxis. So usually, iron and calcium supplementation is started when the nausea and vomiting settles. Okay, usually around 14 weeks. So recommended prophylaxis includes 100 milligram of elemental iron and 1 gram of calcium daily during pregnancy. So 100 milligram of elemental iron and calcium is 1 gram. 1 gram of calcium is required daily during pregnancy. So Government of India recommends the intake of at least 100 iron tablets containing 100 milligram elemental iron during pregnancy, which is provided free of cost to all pregnant women. So coming to some high yield points regarding immunizations that can be given during pregnancy. Vaccines that provide active immunity like tetanus toxoid and diphtheria toxoid, rabies, hepatitis A and B, vaccination against pneumococcal, meningococcal and hemophilus, and immunoglobulins for post-exposure prophylaxis, hepatitis A, B, tetanus, rabies, varicella, measles, all of these are immunizations which can be given during pregnancy. not only TT but also rabies, hepatitis AB, and pneumococcal, meningococcal, and immunoglobulins for post-exposure prophylaxis like hepatitis AB, tetanus, rabies, varicella, measles. Now, immunizations that are contraindicated in pregnancy. Very, very important Viva question. So, what are the immunizations that are contraindicated during pregnancy? First is measles. You should not give measles because it's a live viral vaccine. Mumps is contraindicated. Varicella zoster is contraindicated. All these three vaccines are contraindicated during pregnancy. Now next you need to ask for signs, symptoms and signs of preeclampsia. So what are the symptoms of preeclampsia generally? So excessive weight gain, swelling of feet, decreased urine output, headache, blurring of vision and epigastric pain. So these 5 things: excessive weight gain, swelling of the feet, decreased urine output, headache, blurring of vision and epigastric pain. Excessive weight gain, swelling of the feet, decreased urine output, headache, blurring of vision and epigastric pain. All these are symptoms suggestive of preeclampsia. So the importance of excessive weight gain. So what is the importance of excessive weight gain? So the normal weight gain during pregnancy is generally around 10 to 12 kg for an average Indian woman. So the weight gain is distributed as 1 to 2 kg in the first trimester, 5 kg in second trimester and another 5 kg in third trimester. So 5 for second, 5 for third and around 1 to 2 kg during first. So totally it's going to be around 10 to 12 kg. 1, 5 and 5. So weight gain should not be more than 0.5 kg in a week or more than 2 kg in a month. Very important. So weight gain should not be more than 0.5 kg in a week or more than 2 kg in a month. So importance of swelling of feet is, so the causes and characteristics of swelling of feet during pregnancy are: first, so swelling can be divided into 2 things. One is physiological edema, another one is pathological edema. So physiological edema, the cause is physiological edema of pregnancy develops due to pressure of the gravid uterus over the inferior vena cava, thereby decreasing the venous return. So that is the main cause of physiological edema during pregnancy. Basically, there is going to be pressure of the gravid uterus over the inferior vena cava, thereby the venous return decreases. So characteristic usually develops in the third trimester. It is relieved by rest and it is a dependent edema. So pathological edema causes are pregnancy induced hypertension, congestive cardiac failure, anemia, hypoproteinemia and renal failure. So these are the causes for pathological edema. So characteristics can present in any trimester, not relieved by rest, can develop in non-dependent sites such as abdomen, hands, face and vulva. Pedal edema is not included in diagnostic criteria for preeclampsia. Headache, blurring of vision, epigastric pain, and decreased urine output are generally imminent symptoms of eclampsia. So remember, pedal edema is not a diagnostic criteria for preeclampsia. Okay. Now next, very commonly asked Viva questions are regarding the screening for gestational diabetes mellitus. So the universal screening for gestational diabetes mellitus is recommended in the first antenatal visit. Okay, during the first antenatal visit and repeated at 24 to 28 weeks when the glucose intolerance during pregnancy is maximally manifested. So when is the glucose intolerance manifested maximum? Around 24 to 28 weeks. Now moving on to the ultrasonography in second trimester. So the ultrasound is mainly to detect fetal anomalies, is usually done between 16 and 24 weeks. Usually done between 16 and 24 weeks. So the importance of history taken in third trimester is number of antenatal. Okay. So this is all about the importance of history taken during the second trimester. So far in second trimester, we saw the number of antenatal visits, TT immunization, quickening, the bleeding PV in second trimester causes, drug intake, what are the immunizations contraindicated in pregnancy, symptoms of preeclampsia, causes for swelling of feet in pregnancy, screening for GDM, ultrasonography in second trimester, that is during 16 to 24 weeks. Now let's move on to the importance of history taken in third trimester. So first you'll ask for the number of antenatal visits for the booking status, then perception of fetal movements just to assure that the fetus is alive. Now history of bleeding per vaginum in the third trimester. Very important question. So what are the causes of bleeding PV in third trimester? So you have both physiological cause and pathological cause. Physiological cause of bleeding PV, especially in the third trimester of pregnancy, is known as SHOW. Very important question, guys. What is SHOW? So SHOW is nothing but passage of blood-stained discharge per vaginum with the onset of labor is known as SHOW. So what is SHOW? SHOW is nothing but passage of blood-stained discharge per vaginum with the onset of labor is known as SHOW. So it is a physiological cause of bleeding bleeding PV in the third trimester of pregnancy. Now next moving on to the pathological causes. So the pathological causes are going to be antepartum hemorrhage, placenta previa and abruption. So what are the pathological causes? Antepartum hemorrhage, placenta previa, abruption. So these three are the important pathological causes for bleeding PV in third trimester. Antepartum hemorrhage due to placenta previa and abruption. Any scar rupture in case of previous cesarean pregnancy. Any local lesions like cervical erosion, carcinoma cervix, cervical polyp, etc. Now next, how is a fetal kick count kept? So what is this fetal kick count and how it is kept? There is a formula, okay? Cardiff's count to 10 formula. What is it? Cardiff count to 10 formula. So here, according to this formula, the patient starts to count the fetal movements from a particular time in the morning. The counting comes to end as soon as 10 movements are perceived. And then admitted patients are usually given a thread and asked to make a knot during each fetal movement. Perception of less than 10 fetal movements over 12 hours on successive days or no fetal movement over 12 hours in a single day is considered abnormal. Now, what do you mean by antepartum hemorrhage? Define antepartum hemorrhage. So, any hemorrhage. Antepartum hemorrhage refers to any bleeding, okay? Bleeding from or into the genital tract after 28 weeks of gestation but before the delivery of the baby is known as antepartum hemorrhage. So what is the definition of antepartum hemorrhage? Antepartum hemorrhage is nothing but any bleeding from or into the genital tract after 28 weeks of gestation but before the delivery of the baby. So the most two important causes for antepartum hemorrhage is placenta previa and abruption. So what is placenta previa? Placenta previa is a condition where the placenta is attached partially or completely to the lower uterine segment, and therefore the bleeding occurs due to a shearing effect between the placenta and the uterine wall when the lower uterine segment gets formed. So abruption. What is abruption? Premature separation of a normally located placenta. So any premature separation of a normally located placenta is known as abruption. It is usually the placenta separates only after the delivery of the baby. So this is all about a brief about antepartum hemorrhage. So antepartum hemorrhage definition is bleeding after 28 weeks of gestation but before the delivery of the baby. The two important causes are placenta previa and abruption. So now coming to the history of drug intake. The patient is advised to take iron and calcium supplementation throughout pregnancy. So the symptoms of preeclampsia we already discussed under second trimester itself. That's the same symptoms: swelling of the feet, blurring of vision, headache, decreased urine output, all of them. So let's just revise once again. Yeah, excessive weight gain, swelling of feet, decreased urine output, headache, blurring of vision, and epigastric pain. These are the symptoms suggestive of preeclampsia. So next, coming to the history of abdominal pain. So causes of pain in abdomen in third trimester. So what are the causes of pain in abdomen during third trimester? So there are two kinds of causes. One is the obstetric cause, such as labor pain, abruption, scar dehiscence in previous cesarean section. Non-obstructive causes like medically peptic ulcer, urinary tract infection, surgically appendicitis, cholecystitis, gynecologically a red degeneration of fibroid, twisted ovarian cyst, all of this. Okay, so the causes of pain in abdomen in the third trimester: obstetric causes are labor pain, abruption, scar dehiscence in previous cesarean section. Non-obstetric causes: medically peptic ulcer, urinary tract infection, surgically appendicitis and cholecystitis, gynecologically red degeneration of fibroid, twisted ovarian cyst. Okay, so how will you differentiate between a true labor pain and a false labor pain? So true labor pain is where there is increase in frequency, duration and intensity of uterine contraction as time advances. So there will be an increase in the frequency, duration, intensity of uterine contraction. So pain in the lower back will be there, radiating to the front of the abdomen and thighs. It is associated with cervical changes, that is the cervical dilatation and effacement. It does not subside with enema or sedation. So false labor pain, you get irregular uterine contractions, lower abdominal pain mostly, not pain in the back, lower abdominal pain mostly if it is a false labor pain, not associated with cervical dilatation or effacement. It subsides with enema or sedation. So false labor pain, if you just give an enema or sedation, it subsides. Whereas true labor pain does not subside with enema or sedation. Next, coming to history of leaking PV. So, history of leaking PV generally implies rupture of membranes. So, what is premature rupture of membrane? PROM. Yeah, so what is premature rupture of membrane or pre-labor rupture of membrane? So, it refers to rupture of membranes before the onset of labor. So, in PROM is divided into term PROM, that is when the rupture of membrane occurs beyond 37 completed weeks but before the onset of labor, and preterm PROM, that is when the rupture of membrane occurs prior to 37 completed weeks of gestation. So, clinical diagnosis of rupture of membranes is history of leaking per vagina, speculum examination to look for any leaking of liquor, Valsalva maneuver, that is ask the patient to cough and look for escape of liquor. Now, so this is we discussed all the points of history in detail in first trimester, second trimester, and third trimester. So the continuation will be in the next video. So to watch more videos regarding this topic, uh, or please do subscribe, share, and like.